BP is a physiological variable. Since blood pressure is a physiological variable, it is influenced by a lot of things. It is influenced by the neurohumoral mechanisms. Uh, it is it varies from day by day. It varies from minute to minute. So your blood pressure will not stay static for even hours. So it's a reality that the BP varies. Then we do not know what is the clinical significance of the BP variability and whether this BP variability has influences the outcome of high blood pressure. So let me discuss in the next 15 to 20 minutes. I'll discuss about whatever evidence is available regarding variability, BP variability, and what are the different parameters you look at, what is the current concept regarding its influence or impact on the hypertension related outcomes. So this is, as you all can understand, this is the ambulatory blood pressure monitoring. This is ambulatory blood pressure monitoring of one of my patients. You can see the ambulatory blood pressure monitoring. You can see that the blood pressure doesn't stay same as you expect. It increases, it decreases, it increases, it decreases, then it dips. So it changes minute to minute, hour to hour, day to day. And you can see during sleep, there is a dip, and this dip is normal. Normally, the blood pressure dips by around 10 to 20%. And that is a normal dipping. Certain people, there won't be any dip, rather there can be an increase in the blood pressure during night, which is known as the reverse dipping. Sometimes there can be even an excessive dipping. And this is an important tool. The ambulatory blood pressure monitoring is an important tool in assessing the BP variability, especially because most of the time we use the ambulatory blood pressure monitoring for 24 hours. So hour to hour BP variability is, this ambulatory blood pressure monitoring is an important tool to detect the hour to hour blood pressure monitoring. So you can see in this slide, you can see the variability of the blood pressure. 9 a.m., you can see what is the systolic and the diastolic blood pressure. It is somewhere around 120 over 80 millimeters, and by 12 a.m., between 12 a.m. and 3 a.m., at 3 a.m., you can see that the systolic blood pressure has gone down to 100 by around 12 or 12:30 a.m. And at 3 a.m., you can see the diastolic blood pressure has peaked to 60. Again, at 9 a.m. in the morning, the systolic blood pressure has gone up to 140, and the diastolic blood pressure has gone up to 100 millimeters of mercury. Then you can see that line, it is not a straight line. Graph is not at all a straight line. It is a bump beating. So this is quite usual and this is quite natural. The blood pressure being a physiological variable, it is influenced by a lot of things, the hormones, the neural, the reflex, lot many things. And it produces what you call a BP variability from BP variability, minute to minute BP variability, and the day-to-day BP variability and long-term blood pressure variability, visit-to-visit blood pressure variability. So this is the home blood pressure monitoring. So there are important tools that we use nowadays to look at the blood pressure variability, or rather we gained or we have come up to this concept of BP variability from these tools like ambulatory blood pressure monitoring, home blood pressure monitoring, and also multiple office blood pressure monitoring during the patient's visit in the clinic. So you can see the home blood pressure monitoring at various times on various days, the day 1, 3, 5, the blood pressure is different. So this you can see at the evening, what is the blood pressure, during the wake hours, during sleep, there is a lowest blood pressure period, pre-awake blood pressure a little high. In the morning blood pressure, it is there is a morning surge. So something like a sleep through surge or a pre-waking surge, then the rising BP surge. So morning blood pressure minus lowest nighttime systolic blood pressure is the sleep trough surge. Then the morning systolic blood pressure to the pre-wake systolic blood pressure is the pre-waking surge. The morning systolic blood pressure on rising, the difference between this and the systolic blood pressure on supine less than 30 minutes before rising, that is a rising BP surge. And the morning systolic blood pressure difference between the evening systolic blood pressure and the morning systolic blood pressure, this is the mean difference of the systolic blood pressure. This is seen in the, or this is usually evaluated by using a home blood pressure, usually self-measured home blood pressure measurements. So you can see the morning to evening difference that is in the home monitoring, home blood pressure monitoring. You can see one of the patients this is the ambulatory blood pressure monitoring, and here you can see he is a excessive dipper. You can see the dipping is more than 20 millimeters of mercury. So his blood pressure is relatively controlled, though there is ups and downs in the systolic blood pressure and the diastolic blood pressure, but during sleep there is an excessive dipping. This is known as the excessive, it is more than 20% of his normal awake blood pressure. So this is an excessive dipper or a super dipper. You can see the dipping is more. And in the morning, there is immediately after awakening, there is a surge of the blood pressure. So what is the true blood pressure? Is it the average blood pressure? Is it mean blood pressure? It's ambulatory blood pressure? Is it the night blood pressure? Is it the wake hours blood pressure, something like the daytime blood pressure? Is it the nighttime blood pressure? Is it the home blood pressure? Is it the clinic blood pressure? Is it the 24-hour mean blood pressure? Or is the dipping pattern? So blood pressure, different things are there. It is not a single measurement. It is not a single measurement that produces the impact of the high blood pressure on the various or target organs. So all these things are important. What is the awake blood pressure? What is the dipping pattern? What is the nighttime blood pressure? So nighttime, the dipping, the morning surge, 24-hour mean blood pressure, the variability of the blood pressure, and clinic blood pressure. So for most of the studies, majority of the hypertension trials and the evidence available is with clinic blood pressure, and we get all our recommendations and validations are based on the clinic blood pressure measurement. So all the major studies have used clinic blood pressure measurements, and the outcome benefits and the outcomes were all evaluated with the clinic blood pressure. But of course, then new things are coming up. The importance of newer things, we are finding the importance of the newer thing, and this will improvise and helps to improve the outcome in hypertension patients, which is the major public health problem of the world. So BP variability, rather than you can see, it is rather than representing a background noise or a phenomenon occurring at random. These variations are known to be the result of complex interaction between extrinsic environment and behavioral factors and intrinsic cardiovascular regulatory mechanism. It is neural, central, neural reflex, humoral influences, and these are not yet completely understood. So various mechanisms, multiple systems, including the nervous system, the neural reflex, the humoral influences. So all these things combined together influences the day-to-day variation, the minute-to-minute variation of the BP. So blood pressure variability is known to be the result of a complex interactions between the extrinsic environmental and behavior factors and intrinsic cardiovascular regulatory mechanisms. So extrinsic environmental factors, the behavioral factors, and the cardiovascular regulatory mechanisms. So all these three things work together. They play a major role in the blood pressure variability. You can see a patient A and a patient B. The patient A, we see three blood pressure measurements, 140, 125, 120, we see 235, we see 345. So the average blood pressure is 140 and the standard deviation is 5 millimeters of mercury. So this is the visit to visit BP variability. And the first three measurements, there is an average blood pressure of 128 with a standard deviation of 10. This is the within individual variability. So the intra-individual variability, visit to visit BP variability, the visit 1, visit 2, visit 3, what is the variability? In the first visit itself, multiple blood pressure measurements and the variability. Patient B, you can see the same thing. The within individual variability is 140 average with the standard deviation of 5. And the visit to visit variability, you can see the third visit, it is 160 millimeters of mercury blood pressure, and the standard deviation is 20. So the second patient's got a higher BP variability than the first. Inter-individual variability, the patient A, we can see 140 blood pressure, patient B 160, patient C 180. And a drug X was given to the patient 1 and the drug Y second. And you can see the drug X patient The drug X, when drug X was given, patient A developed 130 millimeters, 140 millimeters B, and 150 by C. Average is 140 and the standard deviation is 10. With drug Y, it is 130, 140, and the patient C, it is 180 millimeters of mercury with a standard deviation of 26. So different drugs, its influences, it use the proper intake of the drugs, a lot of things. It's interaction of actually BP variability is interaction of multiple things, including the behavioral changes, the external environment, and the intrinsic cardiac regulatory mechanisms. Within an individual, over time varies from one patient to another. You can see the BP variability. Patient 1 with a lower BP variability and patient 2 with a higher BP variability, both systolic and diastolic blood pressures. The circadian variation in the blood pressure and neurohormones. A prominent circadian variation has been demonstrated for plasma renin activity, angiotensin II, aldosterone, atrial natriuretic peptide, and catecholamines. And these are the hormones which are involved in the control of blood pressure. So there is a strict circadian variation for the RAS system: angiotensin, aldosterone, renin, atrial natriuretic peptide, and catecholamines. So all reflecting the marked circadian structure of the RAS system. You can see the blood pressure changes. The hormone also changes. The plasma adrenaline changes. The plasma noradrenaline changes. Aldosterone changes. So all these things, the external influences, look, respiration, emotion, exercise, meals, tobacco, alcohol, pain, temperature, all circadian variations, a lot many factors influences the blood pressure. So a given blood pressure at one point of time on a day may not be the correct blood pressure he is having. It may not tell us the exact blood pressure burden on that particular patient. And all standard recommendation of BP measurements is patient to be calm, no caffeine within the last 30 hours, no smoking, and he should take rest and be there in the OPD. Or wherever you are taking the blood pressure, be there for at least 30 minutes before taking rest and properly seated, properly. The blood pressure apparatus should be properly connected, and preferably try to avoid things so that if possible nowadays, most of the time it is the self-monitored office blood pressure measurement. So the patient himself then can look at the automated blood pressure apparatus and take their blood pressure, so that a big problem of the white coat hypertension can be, we can take away the chance of white coat hypertension to a big extent, though it is not completely possible with these things. So what are the factors that control this? In the central nervous system, it is the stress, the emotion, exercise, circadian rhythm. The neural factors: sympathetic nervous system activity, the parasympathetic nervous system activity, the baroreflex system. The humoral factors, mostly it is RAS system and the endothelial system, the salt intake, overeating. Then the vascular factors like stiffness of the conduit artery, compliance of the resistance artery, vascular remodeling, the climate and the environment. So everything together, the neural factors, hormonal factors, reflex system, external factors, stress, emotion, exercise, so circadian rhythm, the climate and the environment, and the vascular factors. So neuro, hormonal, vascular, reflex, environmental, everything together produces the blood pressure variability. It is expressed as the standard deviation of the average blood pressure. Blood pressure variability is based on the calculation of the standard deviation of the mean of all individual BP values recorded over 24 hours. We have various parameters: standard deviation, coefficient variance, day to night BP changes, the average real variability, residual blood pressure variability, trough to peak ratio, night to day change, a lot of things, and many of them requires ambulatory blood pressure monitoring or home blood pressure monitoring. Some of them require only clinic blood pressure monitoring. So for a continuous beat-to-beat BP recordings, we look at the standard deviation, repeated office blood pressure measurements, standard deviation, coefficient of variation, and average real variability can be looked at from repeated office blood pressure measurements. 24-hour ambulatory blood pressure monitoring, all these things, standard deviation, CV, residual blood pressure variability, the average real variability, day to night, and morning surge to pre-wake surge, all these things, trough to peak, night to day, all these things. And from the home blood pressure monitoring, we can have a look at the standard deviation and the coefficient of variance, and visit to visit, standard deviation and coefficient of variance. Another new index that is coming up is the smoothness index, which can, the smoothness index tell us the impact of the blood pressure lowering drug, how much BP variability is influenced by the drug. So it can assess the amplitude and distribution over time of blood pressure reduction, amplitude and distribution over time of blood pressure reduction by treatment, 24-hour BP changes and standard deviation, by standard deviation. So the coefficient of variance, standard deviation by the blood pressure into 100, residual blood pressure variation, fast fluctuations that remain after exclusion of the slower components of the 24-hour profile through spectral analysis, and average real variability, the BP2 minus BP1 plus BP3 minus BP2 plus BP4 minus BP, so go on. These variations divided by the number of measurements. Day to night, the dipping status, night to day, the morning surge. So these things are easily, you can make out all these things from the ambulatory blood pressure monitoring. So these are the very short-term blood pressure variability, that is beat to beat. Short-term, within 24 hours. Long-term, day to day. Long-term, very long-term, that is visit to visit. Continuous BP recordings in a laboratory setting, you can look at the beat to beat blood pressure variation. Or 1 minute to 24 hours variable recording periods. Short-term ambulatory blood pressure monitoring for 24 hours, every 15 to 20 minutes, extensive information of 24-hour BP profile, identification of patterns of circadian BP variation. Only problem is it's not easy to repeat it frequently. You can get the 24-hour, the daytime, day-night standard deviation and coefficients of variations, 24-hour weighted standard deviation, day-to-night BP changes, and the ARB. And the long-term ambulatory blood pressure more than 48 hours, usually we don't do. Better will be a home blood pressure monitoring. We have to train the patient regarding the home blood pressure monitoring. Long term, that is basically visit to visit, either home blood pressure monitoring, ambulatory blood pressure monitoring, or office blood pressure monitoring. The visits are spaced over weeks or months or even years, and it is appropriate for long-term monitoring. And the types of blood pressure variability, their determinants and prognostic relevance, though it looks very complicated. One thing is for sure, there is very short-term variability, the short-term variability, the mid-term variability, the long-term BP variability, and the very long BP variability. So all these type of variabilities, these are influenced by the reflex systems, the neural systems, the humoral systems, and of course, other external influences, the environmental influences, behavioral changes. So all these things, along with the drugs for blood pressure, the correct timing, the correct dose, the time of taking of drug, missing of drug, arterial compliance, all these things, the compliance to medication, all these things influences the BP variation. And the variability in turn has an impact on subclinical organ damage, the cardiovascular events, the mortality, renal outcomes, EGFR, and albuminuria. So all these things. So all the outcomes of blood pressure, high blood pressure, like the target organ damage, mortality, cardiovascular disease, cardiovascular mortality, cardiovascular events, renal events, all these things are influenced by long-term or short-term or even very short-term blood pressure variation. And we have evidence on these things. Blood pressure variability and cardiovascular disease systematic review and meta-analysis published in 2016. We can see all these studies have shown one thing: benefit of the hazard ratio is less with less variability. So cardiovascular diseases, all these things, the studies of all these studies have shown that even the random effects, the meta-analysis of these are all from ambulatory systolic blood pressure, ambulatory systolic blood pressure, and check and correlated with case mortalities. So everything favors decreased variability. Decreased variability means better cardiovascular events, less cardiovascular events, less mortality with less BP variability. The Ohasama study can see the cardiovascular mortality according to the profiles of day-by-day blood pressure variability. Can see the standard deviation of BP variability Q4. The quintile with maximum BP variability has the maximum cardiovascular mortality. The Q1 with the minimum BP variability has got the minimum cardiovascular mortality, the lowest. So, and you can see the big difference between the two Kaplan-Meier curves. Diastolic BP also similar. So variation in the blood pressure was associated with the cardiovascular mortality. More the variation, more the mortality. Day by day variability of home blood pressure and incident cardiovascular disease in the clinical practice, the J-HOP study, they looked at Japan mornings, the Japanese population, the morning surge to home blood pressure. So you can see the systolic blood pressure, the quintile with the highest variability. They look at the coefficient of variance, the ARV, and the WIM systolic blood pressure. And all the three things you can see, more the variability, more the hazard ratio for a cardiovascular disease events for all these parameters, the CV, ARV, and WIM, all these things has shown that there is an association with the risk hazard ratio for cardiovascular disease events. That means only one thing, more the variability, more the risk for cardiovascular events. The J-HOP increased hypertension mediated organ damage, increased incident cardiovascular events independent of the mean home blood pressure, and a better predictor of cardiovascular disease and end organ damage. This is what the J-HOP told us. More the variability, more organ damage, more the variability, more cardiovascular disease events. And it is a better predictor of cardiovascular disease and end organ damage. Subclinical target organ damage and BP variability. You can see the mean arterial pressure variability. You can see the more the variability, the group with the highest variability has got the highest rate of target organ damage. Visit-to-visit variability and risk of stroke and coronary events in the UK TIA and the ASCOT BPLA trial, you can see more the variability, more chance that the hazard ratio is higher. The hazard ratio is higher for risk of stroke in the ASCOT BPLA for the risk of stroke as well as for the coronary events, and more for the risk of stroke. The BP variability has got more impact. And stroke is a more sensitive endpoint for the connection between BP variability and an end organ and an event, cardiovascular disease event. Long-term visit-to-visit blood pressure variability and renal function decline in patients with hypertension over 15 years. 2016 data, long-term visit-to-visit variability is an independent determinant of the renal deterioration. So all the endpoints, stroke, cardiovascular disease, coronary events, as well as renal events, patients who are exhibiting more variability, there is more of organ damage, more of cardiovascular event. So every effort should be made to reduce the BP variability in order to slow down the decline in renal function. You can see INVEST trial, the INVEST study, visit-to-visit variability. So those patients with a less than 25% control of blood pressure, 25 to 50% visits control of blood pressure, 50 to 75% time it's blood pressure control, and more than 75% time the blood pressure control. So these are the different groups. And you see the risk for an MI, the risk for a stroke, both are higher in those people with less control of blood pressure, less than 25%, or 25 to 50% of the time the blood pressure is controlled, rest of the time it is uncontrolled. So more BP variability, more the chance for MI and stroke. And cardiovascular fatal events in relation with the diastolic blood pressure variability, there is data in 2012 which shows even diastolic variability also has got an impact on the cardiovascular event rate. This is the smoothness index I was mentioning. This is the ratio between the average of 24-hour blood pressure changes induced by a drug and its standard deviation. So when the smoothness index is positive, you can see the smoothness index, the time from drug intake and hours. So you can see the intimal medial thickness, the smoothness index is higher, the intimal medial thickness is lower. So as the smoothness index goes high and high and high, that means the problem with the atherosclerosis comes down. So whenever you use a drug, it should produce a smooth control of blood pressure without more undulation. So that is the entire, behind the exercise of this effect of blood pressure variability, its impact on target organ damage, its impact on cardiovascular events. What we are trying to make out a point, only one point, we are trying to make out only one point. That means you should use a drug in hypertension which can produce a smooth control without much undulation so that the target organ damage will be less, the event rate will be less. So this, the effect of antihypertensive agents on blood pressure variability. Placebo, candesartan, indapamide, and amlodipine. And you can see the yellow one, that is the amlodipine, is of the three agents. Amlodipine seems to have a better impact on short-term BP variability. The BP variability, the short-term blood pressure variability was found to be least with a longer-acting calcium channel blocker. Beta blockers and calcium channel blockers on within individual variability in blood pressure and risk of stroke, you can see amlodipine versus atenolol. The red is atenolol and the blue is amlodipine. A better, so during the follow-up, they have found that a better reduction in the BP variability was found with the amlodipine group, and those people had a lower event rate. The risk of stroke was lower in those patients who had a lower BP variability, which was produced by the use of an amlodipine when compared with atenolol. So most of the studies, when we found that atenolol was not good and there was no reduction in the stroke, maybe due to the fact that it produced a lot of blood pressure variations. That could be the reason why atenolol was less effective. It was not good in preventing stroke. It was in certain cases, it was even detrimental. Effects of antihypertensive drug classes on inter-individual variation in blood pressure and risk of stroke. This has also shown, you can see if you look at the different antihypertensive classes, the best considered to be found to be calcium channel blocker. And then the diuretics. So calcium channel blocker and diuretics were found to be better agents among all the other antihypertensive agents regarding correction of BP variability. Beta blockers are the worst. So drug class effects on inter-individual variation in blood pressure can account for differences in the effects of antihypertensive agent on risk of stroke independently of effects on mean systolic blood pressure. So it's not its effect on mean blood pressure that is important, how much smoothly it controls the blood pressure and how much it can take away the fluctuations in the blood pressure is also important. So to conclude, I must say blood pressure variability is a complex phenomenon. Adverse cardiovascular consequences of high blood pressure is not only due to mean blood pressure, but may be related to the BP variability also. Short-term and long-term BP variability is associated to the development, progression, and severity of cardiac, vascular, and renal damage. So it's important the development, progression, and the severity of cardiac as well as vascular and renal damage and increased risk of cardiovascular events as well as mortality. So blood pressure variability is important. Then how to measure, whether we should measure it routinely and how we can get rid of this blood pressure variability. These are the things that are important for us because it's a huge problem. More than 1 billion people around the world are affected by hypertension. This is the official. It may be much, much more. It's the most important correctable cardiovascular risk factor. Inter and intra-individual visit-to-visit blood pressure variability are strong predictors of cardiovascular morbidity and mortality. So what we require is avoid BP variability, a better and a smooth control of blood pressure. These two things are important. A smooth control of blood pressure without undulation is important in improving the outcomes in patients with high blood pressure. Inconsistent blood pressure control and large differences in BP from one clinic visit to other should be avoided. This may be achieved with a proper dosing, timing of drugs, adherence to treatment, as well as use of combination of long-acting drugs. That's the area where long-acting drugs and its combinations have got an impact in the outcome and the outcome of hypertension. So they may have an edge over short-acting drugs. A combination of two long-acting drugs will be much, much better in reducing the blood pressure variability. So the dosing is important, the timing of the drug is important, and the adherence is important, as well as the duration of action of the drug. But there are a lot of unanswered questions. What is the ideal measure of blood pressure variability? We do not know. Should we routinely check for blood pressure variability? That is the most important thing. We are not sure. We need more data. Should we target BP variability to improve outcomes? We don't know. And what is the optimal target blood pressure variability? So these are unanswered questions. So at the end of the talk, I don't know whether I've put more questions and more confusion rather than answers. But let me make it one thing. The most important take-home measure from this session is that you should reduce the blood pressure variability. How? A better control of blood pressure, a better control of mean blood pressure, using long-acting drugs, using the correct combination of drugs with long-acting smooth actions, the proper dosage and proper timing, so that there should not be much big fluctuations in the blood pressure during over the 24 hours. So reduce blood pressure fluctuations by a better control, because when the blood pressure is better controlled, the fluctuations are less. So a proper selection of the drug, proper selection of the drug combinations, proper timing of the drug administration, proper dosing of the drug administration, and ensure the compliance, ensure the adherence to therapy. These are the practical things by which we will be able to reduce the blood pressure variability, to improve the outcomes, and to reduce the target organ damage. Thank you. Thank you so much.